الآن الدكتور خالد صالح، محاضرة بعنوان Preliminary Genetic Insights Neurological Disorders in Resource Limited Setting in Yemen. تفضل دكتور.
خلاص كده. السلام عليكم. هذا مش تبعي هذه.
دكتور خالد، الدكتور حافظ انه بس يشتي تعليق او كلمه.
دكتور إيمان الدواء وين المايك الثاني؟ طبعا عرفت نفسي مرة أخرى دكتور حافظ النود. طبعا كل التكنولوجيا هذه ممتازة جدا، لكن كمان احنا عالم تعرف يعني حاجات يعني قادرين على تطبيقها. في هناك حاجة اسمها Southern Approach Analysis. Southern Approach Analysis هي من ضمن مجموعات الجينيتيك، وهي بتشمل اساسا للحالات الديليتيشن. ليش ما حصل له شيء يعني حد ذكرها في المحاضرات، وهي مهمه في الباثالوسيميا، والباثالوسيميا منتشره عندنا حوالي الا 9%. شكرا.
خالد تفضل. جاهزين يا شباب؟ وين
اوكي.
القاعة؟ الرجال الهدوء لو سمحتم.
السلام عليكم.
من بيخرجوا يا وثاب؟ من بيصيروا؟ يحضروا. طيب المحاضرات أهم من التحضير. هدوء لو سمحتوا. تفضل دكتور خالد.
السلام عليكم. I am initiating a genetic study for neurological disorder, and this is the conceptual framework of this study, and inshallah I will expand. I plan to expand this study with collaboration with others who are interested in this field. So I will start with background. Neurological genetic disorders in low resource settings are often underdiagnosed, misdiagnosed, or diagnosed very late. And genetic causes are increasingly recognized worldwide. And there is a limited access to genetic testing in low resource settings. And in Yemen, we have a special situation because we have a higher percentage of consanguinity, about 40 to 50%. And also there is a limited diagnostic, there are limited diagnostic resources. What is the aim of this study? Is to evaluate the diagnostic yield of genetic testing and to identify common genetic disorders, neurological disorders, and phenotypes. The total patient we have seen in the previous 2 years is about 100 patients. About 36% of them are males and 37% are females. So there is a clear male predominance in this study. What are the genetic tests used? In the majority of cases, the used test was whole exome sequencing and also sometimes whole genome sequencing and targeted genetic test in some situations. How are the data are collected? According by the clinical phenotype, age at diagnosis, family history, and genetic results. The diagnostic yield, the positive result were 50%, the negative were 29%, and the variant of uncertain significance were 21%. Most common genes which are detected are Duchenne muscular dystrophy gene and the survival motor neuron type 1 gene, CAP3, which is very important in the structure of muscle fibers. So if this gene is defected, there will be a muscular problem. GNE gene also involved in muscular dystrophies and the spastic paraplegia elephant gene. Other genes are TRAC1 gene, which is encoded for serine active site containing one. This is very important in the mitochondrial function. FMR1 gene and LDH18A1 gene. So from these detected genes, the neuromuscular genes were clearly dominant. What are the disorders which are detected by the genetic studies? The most common were neuromuscular disorders, Duchenne muscular dystrophy, limb-girdle muscular dystrophy, and motor neuron disorders, especially spinal muscular atrophy, and especially adulthood type, and neurodevelopmental disorders like Fragile X, epileptic encephalopathies. Metabolic and mitochondrial disorders like Mechdel syndrome, Tay-Sachs, phenylketonuria, propionic acidemia, mitochondrial disorders. And neurodegenerative disorders like hereditary spastic paraplegia, dystonia, and young onset Parkinsonism disease, and ataxias. For whom? من المرضى اللي احنا المفروض نرسل لهم genetic studies? Those people with progressive muscle weakness, with developmental delay, seizures, spasticity. Usually motor symptoms were the main entry point to genetic testing. What is the inheritance pattern of these diseases? The autosomal recessive diseases were 60% and autosomal dominant were 15%, X-linked were 20%, and mitochondrial was 5%. Autosomal recessive inheritance is the dominant pattern in this study. Why it is the dominant? Because, you know, in our community there is a high consanguinity, and there is homozygous variance and family clustering. What is the initial presentation of patients? Cerebral palsy, myopathy, motor neuron disease, young onset Parkinson disease, metabolic. Genetic disorders often mimic other specialties. Try to figure out this case. عندي a 40-year-old female patient عندها 3 years history of progressive proximal muscle weakness. Family history of similar condition was present, and we sent for whole exome sequence genetic testing, and the result was CAP3 gene. This gene is responsible for this presentation. It is the pathogenic mutation in the CAP3 gene are associated with autosomal recessive limb-girdle muscular dystrophy type R1 This condition is characterized by progressive muscle weakness affecting the shoulder and pelvic girdle. So it will lead to difficulty in walking and standing and climbing stairs. Another example, a 3-year-old male patient born to consanguineous parents presented with recurrent seizures, recurrent episodes of diarrhea, and significant developmental delay. A brain MRI showed bilateral vitaminal hyperintensities. His brother has the same condition, and on lab there were elevated liver enzymes. I asked for whole exome sequencing, and the result was CRAC1 gene mutation. What is the CRAC gene mutation responsible for? The mutation in the CRAC1 gene are associated with McDel syndrome, methyl glutaconic aciduria with deafness, encephalopathy, and Lee-like syndrome. It is autosomal recessive. Typically, the typical features include developmental delay, progressive neurological deterioration, hearing impairment, spasticity, dystonia, cerebellar atrophy, mitochondrial dysfunction, and increased serum lactate, liver dysfunction, or feeding difficulties. Before ending this presentation, I want to ask two important questions. The first question is, this for audience, is genetic testing recommended even with obvious symptoms? I mean, if the patient has clinical characteristic of a genetic syndrome like tuberous sclerosis, telangiectasia, it is clinically obvious, it is tuberous sclerosis. So, is it recommended to do for this patient genetic testing or not? Yes or no? Yes. Yes, because of treatment plan. أول حاجة confirming the diagnosis. يعني مثلا في tuberous sclerosis معانا 2 genes, tuberous sclerosis 1 and tuberous sclerosis type 2. So we have to identify a precise gene for prognosis and for directing treatment plan if there is treatment. Yeah, I will give you another example. In spinal muscular atrophy, there is treatment, صح? Genetic drugs. This treatment, each treatment has a specific gene direction. يعني for example, SMN1, it has a specific drug, and also SMN2 gene has a specific treatment. So also to direct the future plan of treatment, and also for family planning. يعني عارف هل هذا هو فعلا hereditary or mutation, new mutation, in order to plan يعني for family planning. The second question, does a negative testing rule out a genetic disorder? And this is answered in the first presentation by Dr. Heba. So I want to hear again the answer. Why? Even whole genome sequencing? الإجابة, does a negative testing rule out a genetic disorder? No. 10 إلى 15% ممكن يكونوا negative even لو عملنا الwhole genome sequencing because of novel genes. ممكن يكون جين جديد. بقى مثلا حاجة يسموها موسايسيزم، خلايا متأثرة وخلايا ايش؟ مش موجودة، فممكن يكون التست ايش؟ نيجاتيف. الحاجة الثانية البوليجينيك or multifactorial. So negative testing will not rule out a genetic disorder. Thank you very much.